everyone, and welcome again to the latest ISRRT webinar that is currently streaming to you live on the Facebook Live website. Hello and welcome. Good morning to the Americas, good afternoon to Europe and Africa, and good evening to Asia and Australasia. Today we have a very exciting webinar all about mammography, which is not an area that I am familiar with at all, as I am a paediatric radiographer. My name is Steve Lacey. I am the Director of Education for ISRRT. Very thanks to our European Regional Education Representative, Angeliki, for putting this webinar together for us today. And I'd just like to remind you all to please place any questions that you have for any of the speakers in the chat, and we can run through those at the end of each of the presentations. So just to kick it off, I'm going to start with the first speaker. The first speaker is Maria Alafaki. She's from the breast unit of the first propedeutic surgical clinic of the University of Athens in Hippocratio, in the Hippocratio Hospital. She is a radiological technologist specializing in mammography and stereotactic breast biopsy. She is a researcher in various research programs of Medical School of Athens and participates as a speaker in postgraduate study programs. Maria is a trainer for specialized qualified doctors and breast unit health professionals, and the author of various research articles and papers, among others of the chapter Excellent Mammography of the National Guidelines in Surgical Oncology of the Breast. Maria also renovates her home with her girlfriend and their greyhound. And Maria is giving us a presentation called Tips and Tricks of a Liege Artist Mammography. Thank you, Maria.
Dear colleagues, hello from Greece. I'm happy to be here with you to share my experience in mammography. I would like to thank the ISRRT for the invitation. My topic is the Liege Artist Mammography that we must offer to any woman who lives her life in our hands, because mammography detects cancer in early stage. Perfect mammography detects 85 to 95% of cancers. 20 to 30% of cancers are missed. It is not the ideal screening tool, but is the only one that has shown a decrease in the mortality rate. The breast is our subject, and it's necessary to know what is that radiographers have to visualize. Breast, the symbol of life, is placed on the anterior chest wall in front of the major pectoralis muscle, is extended from the second to seventh rib, is supported by two petals of connective tissue. Contains different types of tissue: glandular tissue, which includes the breast lobus and ducts, fibrous, supportive or connective tissue. Fatty tissue fills in the spaces between glandular and fibrous tissue and largely determines the breast size. Almost all cancers are developed within the glandular tissue, in the ducts and the lobus. The highest percentage of cancers are found in the outer quadrant of the breast. Mammographers must develop unique skills in positioning to acquire the images necessary to capture the whole breast in the fewest number of views possible. Mammography is a low-dose X-ray picture of the breast tissue, a valuable tool to detect the early signs of breast cancer before a woman comes in with symptoms. Liege Artist mammography means perfect image quality with lower radiation dose to minimize the risk of missing a cancer. Optimizing mammography imaging is not a simple process. It requires proper infrastructure, well-trained staff, cutting-edge equipment, and a rigorous quality assurance program. Ensuring access to high-quality mammography services is necessary. This guidance offers a path forward, ensuring that healthcare facilities worldwide can provide the best possible care to their patient. To achieve a high-quality diagnostic mammogram many factors need to be considered. Breast positioning is a key factor affecting mammography performance. Focus on communication skills is pivotal for the patient's experience, and quality control awareness is crucial for diagnostic outcomes in mammography. Today's mammography advancements are digital mammography, digital breast tomosynthesis, breast CT, CVU, SEM mammography. Artificial intelligence, the intelligent companion of radiographers and radiologists, is an open window to the future. Unfortunately, in plenty of countries, our colleagues need to work without mammography advancements. The standard mammographic views are craniocondylar and the mediolateral oblique. Screening mammograms are performed in asymptomatic women. Diagnostic mammograms are used after suspicious results on a screening mammogram or after some signs of breast cancer alert the physician to check the tissue. The European Society of Breast Imaging, the ACR, and the NHS have described specific criteria for perfect mammography. All breast tissue must be imaged. Fat tissue visualized posterior to glandular tissue. Correct image identification is clearly shown. Correct exposure according to workplace requirements. Good compression, absence of movement. Correct processing, absence of artifacts. No skin folds, symmetrical images. The quality of a mammogram is a composite of 5 very specific characteristics: contrast, sensitivity, noise, geometry, glare, artifacts. Necessary condition to produce clearer, sharper, and more detailed breast images. Makes it easier to find microcalcification or potential tumors. Perfect image quality helps to visualize the white cancer tissue through the white glandular tissue. Breast compression is a very important procedure for high-quality images. Reduce the breast thickness uniform, separate breast structure and allow uniform penetration by the X-ray beam, reduce the possibility of motion, reduce the radiation dose to the breast, reduce the object to image receptor distance of the lesion, which helps to depict tissues at their normal size. Compression in mammography needs to be personalized. It depends on the patient's breast and size. The compression should not be applied to cause severe pain to the patient. Women with small breasts receive higher pressure and express higher pain scores. Pain is one of the main reasons that women avoid the mammograms. New technologies give modern tools for the best compression to make women feel comfortable during the procedure. Positioning is the most important factor in the optimization of mammography image quality. Without all breast tissue included in a mammogram or not being optimally visualized, all other aspects of image quality are not adequate. According to the MQSA, of all those positioning failures, inadequate visualization of posterior tissue and the pectoralis major muscle account for nearly half of them. Inadequate breast positioning quality reduces the sensitivity of mammography, is the main cause behind the misdiagnosis of breast cancer in screening mammography. Specific positioning criteria for Legge-Artis CCView. All breast tissue imaged, medial border well demonstrated, nipple in profile, nipple in the midline of imaged breast, posterior nipple line within 1 cm of PNL on MLO view. Tips and tricks of a Legge-Artis CCView. The breast must be elevated to its natural position before it is positioned on the detector. The image receptor is positioned at the level of the right inframammary fold. The patient stands close to the receptor. Mammographer puts the hand on the equivalent shoulder and gently pushes down to aid the relaxation of the shoulder. Optimal compression is achieved if the patient is relaxed. If the breast traction is perfect and the compression is performed adequately, any posterior lesion will be depicted in the image. A missed cancer in inadequate CC view for 2 consecutive years. Specific positioning criteria for a leg artist MLO view: the entire breast tissue within the FOV of mammography, pectoral muscle shadow to nipple level, full width of the pectoral muscle, nipple in profile, inframammary fold, well demonstrated, PNL within 1 centimeter of PNL on CC view. Tips and tricks for a leg artist MLO view: the degree of tube angulation between 30 and 60 degrees, depending on the patient's body. Thin patients require steeper angulation than heavier patients. The correct detector of all compression paddle sizes needed to avoid stretching the pectoralis major muscle. The detector should rest in the armpit posterior to the mid-axilla and anterior to the latissimus dorsi muscle. Compression must adequately support the anterior breast tissue to prevent sagging and distortion of the ductal architecture. The correct use of the image receptor helps to create any positioning. To visualize the muscle shadow, the receptor must be positioned close to the lateral part of the breast, and in this way it's easy to achieve the depiction of the difficult interior lesions. Large breasts need special management to perform the mammogram. Radiographers must create a puzzle to visualize all the tissues, and any piece of the puzzle must cover the other in 2 centimeters. Mammographic positioning depending heavily on the technologist's understanding of the variability of breast anatomy and morphology and the capabilities and limitations of available mammographic equipment. Perfect images, as the rules of image quality are described. Everything works ideally. Screening mammography in breasts with implants is Eklan technique, is a special procedure. Mammographers must be educated to do it in the right way. Breast tissue is pulled forward while simultaneously the implant is pulled back toward the chest wall. Maximum compression is applied only to the breast tissue anterior to the implant. While the implant is excluded, the optimum compression of breast tissue is possible and more breast tissue is demonstrated. A lesion is revealed when the implant is back to the chest wall. To position the nipple in profile, mammographers must stand on the opposite side of the breast that they want to position. They pull the breast in front to put it on the receptor, which is at the right height. Lower than the correct lever, the nipple turns downwards and hides in the retroareolar area. Breast tissue is missed at the side in which the nipple is turned. The nipple must be depicted in profile on at least one view to enable proper visualization of the nipple areolar complex and to avoid mistaking the nipple of the mass. The open inframammary fold is achieved by lifting the breast and bringing the inframammary fold onto the image receptor. A small cancer is revealed in the open inframammary fold. Importance of positioning in early diagnosis for women 80 years old. Adequate images feature a small cancer. Screening mammography for a 65 years old woman. Inadequate images miss the cancer. The patient came to the breast unit for screening mammography. Additionally, she has a PET scan with a lesion in her breast. In current positioning, showed a lesion close to the pectoralis muscle. Returning to prior views, we realize a small part of the lesion because the posterior tissue of the breast is missed. Reject or repeat. It would be better not to face this dilemma by performing perfect images. A woman brought this mammography to our department as screening views. Of course, they are unacceptable. Why reject? An inadequate CC is performed, leaving out of the image the lateral tissue where there is a small team of microcalcifications, a small DCIS. So the rejection is necessary to achieve an adequate CC. Sometimes it is impressive how easily the reject button is pushed. Radiographers must have the ability to avoid rejection by performing the perfect positioning. For any 100 women who came for screening mammography, 10 will return for additional images. These are needed when standard views may not be sufficient for a reliable diagnosis. So portions of the breast that are not seen on standard views characterize an area of clinical concern clearly, counteract superimposition of structures. More useful views are 90-degree lateral, helps a radiologist triangulate when a lesion is only seen in one projection. It's especially useful when lesions are lateral. Medial, 90-degree, show the medial breast in great detail. Exaggerated, CC, lateral, and medial, shows extreme lateral or medial portions of the breast, respectively. In the screening mammogram, there is a lesion on the MLO. An irregular mass is confirmed on exaggerated CC. Magnification view evaluate microcalcifications and its extension. Spot view applying the compression by using a small compression paddle to a smaller area of tissue to visualize the borders of an abnormality or a suspicious developing asymmetry. According to an article in American Journal of Rentgenology, spot compression view could help characterize equivocal digital breast tomosynthesis findings, thus reducing further workup for benign findings. Roll view to separate overlapping tissues, not needed as much because of digital breast tomosynthesis. It's more useful in digital mammography. Cleavage view, medial quadrants of both breasts on the same image. The must-do for perfect images. Recognizing the factors that influence optimal tissue visualization is an art. No technologist with the required talent can produce optimal mammographic images without specialized training and supervised experience. Communication can create special relationship of trust and a good experience for women. Radiographers and radiologists must work as a team for the best results. The use of new technologies which offer major tools, for example, artificial intelligence increases the percentage of early diagnosis through the right positioning in MLO, 92% and 96% in CC. The goal of every breast imaging facility is to not leave a cancer in the room. According to Eklund, poor mammography cannot be perceived without the knowledge of good mammography. Thank you very much for your attention.
Thank you very much, Maria, for that wonderful presentation. It's amazing just to see the importance of positioning and all the other factors that go into a mammogram to make sure that we don't miss any of the breast cancers that occur. Thank you very much. On to our next speaker. Our next speaker is Diana Boskic. Diana graduated from the medical high school in 2008, majoring in as a dental technician. In 2008, she enrolled in the Faculty of Medicine study program in healthcare. She graduated in October 2012 and obtained the academic title of graduate medical doctor. She defended her diploma thesis on the topic of iodine contrast agents. She had an internship for 7 months at the Department of Clinical Radiology, 2 months at the International Medical Center, and 1 month at the Institute for Nuclear Medicine and Thyroid Diseases, and spent the program of the basic part of the internship in the emergency medical service. She's been employed since 2015 to the job of radiology technologist in more complex radiology jobs at the Department of Clinical Radiology of the University Clinical Center of the Republic of Srpska. She independently performs work on digital and mobile X-ray machines, digital mammography machines, and CT machines. She's currently employed at Public Health Institution Health Centre Banja Luka in the Department of Radiology and Ultrasound Diagnostics. In 2023, she participated as a lecturer at the Congress in Jaharina and Banja Luka on the topic of digital mammography and tomosynthesis. And Diana's presentation today is about new technologies in mammography. Thank you, Diana.
Hello, my name is Diana Boškić. Thank you for the opportunity to participate on this webinar. My presentation is New Techniques in Mammography. So let's start. The first attempt to use X-rays in the diagnosis of breast changes dates back to 1913, when the German surgeon Solomon took radiograph of surgically removed breasts and compared the images with operative and hydrological findings. In 1951, Le Bon announced that mammography can reveal details that help distinguish benign from malignant disease. Special X-ray machine for breast imaging, mammograph, was constructed by Egan in 1956. When the industrial production of films and mammographs began in the 60s, mammography began to occupy an important place in the diagnosis of breast disease. From the risk factors for breast cancer, it is important to recognize genetic, anamnestic, and environmental influences. The density, that is the density of the breast, depends on the ratio of the glandular parenchyma and fatty tissue that make up the breast. The relationship between these structures change through life. The most commonly used method for mammographic assessment of breast density describes 4 different categories: ACR1A, ACR2B, ACR3C, and ACR4D. Mammography is a non-invasive diagnostic method by which an image of the breast is obtained with the help of X-rays. Mammography records changes in the breast on average about 2 years earlier than it can be felt. It is the method of choice in diagnosis cancer and monitoring breast changes. Digital mammography is summation two-dimensional imaging method, and there is a significant overlap of breast tissue, which can reduce the sensitivity of the examination and make it difficult to visualize small changes. Digital mammography with tomosynthesis is a 3-dimensional method of breast examination that eliminates overlapping because it is not summation but layered imaging method. It is done on specially designed mammography devices that have an attachment for tomosynthesis. In tomosynthesis, the X-ray tube is rotated around the breast 10 to 30 degrees, and the breast is recorded from several angles. And as a result of the recording, a large number of digital images are created. A large number of patients avoid mammography because of the pain during breast compression. Tomosynthesis requires less compression. Unlike digital mammography, where the image is created so the X-rays enter the tissue and the detector perpendicularly, creating a summation image of the entire volume of the breast through which they have passed, tomosynthesis enables the display of the breast in high-resolution layers without the summation effect. In digital mammography, tissue overlap can cause problems in recognizing normal breast tissue from tumor tissue. The tumor can be overlooked due to the surrounding tissue that covers it in the summation image. Normal breast tissue can be superimposed to look like a lesion because the X-rays pass through the full thickness of the breast. Image acquisition can be done by the step and shoot method. One exposure at each position of the tube between moments, or by the continuous exposure method, pulsed short exposures during continuous movement of the X-rays source. Individual images are then reconstructed into a series of thin, high-resolution layers, typically 1 millimeter thick, that can be displayed individually or in a dynamic sine mode. The devices that are now in use are dual functional. In the same device can be used for two-dimensional digital mammography and for tomosynthesis. Achieving two-dimensional and three-dimensional images in the same compression is called combo mode. Given that the number of clinical studies using breast tomosynthesis is increasing, the advantage of tomosynthesis can be better evaluated depending on the different structure of the breast and possible lesions. This means calcifications, changes, invasive and non-invasive cancers. Scans state that mammography plus tomosynthesis results in a significantly higher rate of cancer detection and allows 40% increase in the detection of invasive carcinomas without an increase in the detection of ductal carcinomas in situ. Study by scanner showed improvement in cancer detection in both density categories breast. This is one of the key advantages of tomosynthesis, the potential for earlier detection in invasive cancers, and precisely the kind that will become life-threatening if not treated in time for effective treatment. Carcinomas that are detected with the help of tomosynthesis are those that would not have been noticed by conventional mammography. The change would not become tankable. Hess, in its clinical study, in which 13,158 women underwent a mammographic examination, and to one part breast tomosynthesis, 6,100 women was added, which reduced the rate of recalls for examination for all groups of breast density, with by statistically significant reduction in callbacks for examination. For diffuse breast fibroglandular density, the reduction is by 25%, heterogeneous density by 39%, and by very dense breasts, the reduction of repeat calls for examination is 57%. Addition of digital breast tomosynthesis in two projections to the conventional digital 1 mammography during follow-up examination resulted in a reduction in recurrence rate score for examination of 29.7%. There was a reduction in callback rates for women of all breast densities and ages statistically significant for all subgroups, except those with predominantly fat density breast and those aged 70 and older. The greatest reduction in the rate of dense breasts, it was found in women under 50 years of age. Research has shown that tomosynthesis gives the best diagnostic results when it is used in combination with mammography and when tomosynthesis is performed on both standard projections, CC and MLO. Also, it has been proven that tomosynthesis increases the number of detected lesions in all breast structures and that it has the best results in denser breasts, where the need for subsequent treatment of patients is reduced by 57%. And 70% of cancers are better or only shown with the help of tomosynthesis. Detection on invasive carcinomas that do not include microcalcifications has increased by as much as 40 to 53%. Detection and analysis of microcalcification is very important in breast diagnostics. Older studies show lower efficiency of tomosynthesis compared to mammography in detecting microcalcifications, but their limitations are a small number of patients and working on a device where the length of the scan is 90 seconds, which increases the possibility of movement artifacts. The fact that the combination of two-dimensional and three-dimensional images of the breast is most often used in a clinical practice is useful here, which enables the selection of the projection that gives the best diagnostic results. Tomosynthesis can be used as a method of choice or as a method for the treatment of symptomatic patients, and in both cases, it gives more diagnostic results compared to mammography alone. In cases where the number of tomosynthesis devices is limited, it is best to use them in patients with denser breasts and as a screening method. The fact is that tomosynthesis is a relatively new method, and there are still some problems that need to be worked on, and those problems are the radiation dose that is the patient exposed, the length of the interpretation of the findings, and amount of data that is archived on the PACS system. On this slide is a representation of digital mammography and tomosynthesis by layers in RMLO and AL-MLO projection combo mode. Mammography is recommended for women over the age of 40 as a regular preventive method. If we are doing mammography, tomosynthesis should be our choice, since we are provided with much more information, the possibility of missing the change in the breast is lower, and because the pressure on the breast is lower, the pain is also lower. Now I want to show you 3 cases on digital mammography and tomosynthesis in both projections, CC and MLO. One is microcalcification, one is cancer, and one is benign change. In the right breast, at the composition of the upper quadrants, and in the medial third of the corpus, oval, slightly lobulated change, within which cluster microcalcifications can be observed. At the composition of the medial quadrant of the right breast, partially spiculated change with malignant characteristics. In the upper lateral quadrant and in the anterior third of corpus, a lobulated homogeneous change with smooth margins. Thank you for your attention.
Thank you, Diana, for a great presentation showing us the differences that can occur between the two-dimensional and the tomosynthesis. They were very interesting to see the results of the difference between the two. So I've certainly learned a lot from that presentation. Thank you very much. Just a reminder to put any questions into the chat on Facebook Live if you have any questions for any of the speakers that we can ask at the end of the presentations. And just moving on to our final speaker, this is a very interesting presentation. This is by Elizabeth Phillips from Australia. So Elizabeth started her career at Sydney Hospital in 1981 as a student radiographer. And once she qualified, she then proceeded to obtain her general ultrasound qualifications. Education is a prominent focus for Elizabeth. She is currently the chair of the Education Committee for ASMRRT, which is the Australian Society for Medical Imaging and Radiation Therapy. She's a clinical tutor for Breast Screen Queensland and a facilitator with the Australian College of Rural and Remote Medicine. Over the past 30 years, Elizabeth has had a keen interest in women's imaging and as much has helped develop and train many colleagues in this field. Elizabeth has recently assisted in the National Guidelines for Remote Assessment Model, which has been formally accepted by the NQMC of Breast Screen Australia. She works as the Breast Imaging Director of Breast Screen Townsville in Queensland, where she has been doing what she loves for the past 19 plus years, and that is helping the ladies of this world. And Elizabeth's presentation is titled Invasion of a Lady's Personal Space, a Radiographer's Perspective. Thank you, Elizabeth.
My name's Elizabeth Phillips. I'm the Breast Imaging Director at Breast Screen Townsville Service in Queensland. I'd like to thank Stephen for the invitation to speak on a subject dear to my heart. Firstly, I would like to acknowledge the traditional custodians of the lands and waters on which this presentation was developed, including the Bindal, the Buckingham and the Kalkadoon people. I pay my respects to elders past, present and emerging. Tactics needed for any invasion includes knowledge of the geography and the transport available for your battle, as well as knowing your enemy's strengths is important. So let's advance forward. So welcome to Queensland, Australia. During this presentation, I will demonstrate how radiographers in Queensland gain compliance from ladies to perform a screening mammogram. As my title alludes to, we do invade a lady's personal space, but we also invade their communities. For our international members, I have included a map of Australia. Here is a map of Breast Screen Queensland Townsville catchment area in pink. We cover approximately 1/4 of the Queensland state. Last financial year, 2022 to 2023, we screened 16,200 clients. As a radiographer, we travel via several different modes of transportation, including land. One town we visit on our 2-year cycle is Camberwell, which is over 1,100 kilometres away from Townsville. It takes us over 12 hours to drive there. Other forms of transport we utilise include boats, planes and container ships to access the communities. Breast Screen Queensland Townsville Service regularly visits Palm Island and Magnetic Island utilising barges for transportation of the mobile unit and our staff. So, as demonstrated, we use land, sea and air transport to cover our vast catchment area to ensure all ladies have the opportunity to have a free screening mammogram. Now, there are many tips and tricks that radiographers can use to gain trust, which will assist in making our clients more compliant. However, it must be stated up front, some ladies are just resistant to all charms and end up being really hard work. And we've all had one of those. Time is critical. Radiographers have approximately 2 to 4 minutes to complete an assessment on how they will gain a lady's trust and perform their mammogram. A screening mammogram usually will only take 8 to 10 minutes, so it is important to get your assessment of your client's needs right. Decor of the mammographic room is very important. It helps relax our ladies. We are a well-woman service, so it is very important not to be too clinical or sterile looking. Artwork also encourages conversation. In Townsville, I am very lucky to have a tropical scene wall art. This allows our clients to meditate or reflect on another place whilst having their procedures done. Our other 2 mammogram rooms also have local area wall art, including the rainforest and the waterfalls that are around us. Personal interaction with our clients is very important. Radiographers are very sociable people and love to chat. This trait assists in making clients feel more welcome and comfortable and make a radiographer's day interesting. Every lady has a unique story to tell us if we stop to listen. So any conversation with your lady will help relax her and make her feel comfortable with you. I can't always remember a lady's name, I must admit, but I certainly notice unusual shoes and accessories. Especially elephant jewellery. For you that know me, I love elephants and often have great conversations with my clients about them. Tattoos are also a good source of interaction. What is it? And why? The feather tattoo was a symbol of freedom. The sisters' tattoo reflects an Indigenous family's reunion, as they had been a part of the stolen generation here in Australia. And the fly tattoo is for the lady's grandson, Louis. Music is also important to have on in the room. It doesn't have to be punk rock. It's much better if it's not, probably. It's better if it's calming and relaxing. It should really match the age group that you are x-raying. So for my ladies, I play the Beatles, Elvis, and maybe even some Rolling Stone, like Brown Betty or Start Me Up. I honestly believe that dressing like a professional is very important. Radiographers are professional and need to be proud of themselves. This will assist ladies to have confidence in your ability. So looking the part is very essential. I'm very proud of my girls, and here are some images of them all dressed ready for a day's work. When we do travel to other community groups or outlying places, we have specially designed shirts for the staff and co-workers. Some of the clientele were involved in their design and their creation. Ladies that participate in these days, these special days, really appreciate that we are there to assist them and looking after their health. Breast Green Queensland Townsville commenced a pilot strategy to give our First Nation clients an incentive gift in September 2021. We called it the Sister Shawls. We had 114 new First Nation women screened between September 2021 to September 2022. The following year, September 2022 to September 2023, another 155 new First Nation ladies were screened. That's a total of 269 new First Nation women who had a screening mammogram with this incentive, both in our static unit and on our mobile. These are some of our clients wearing their sister shawls in our static unit and being very proud and loud about it. The sister shawls are loved by our clients and staff as they offer privacy. The ladies have the choice to wear them as the mammogram is being performed, as they are lightweight and offer privacy. These images of our clients wearing the shawls outside our mobile unit in Mount Isa, which is approximately 900 kilometres away from Townsville. The biggest compliment I have ever received was from an Indigenous client who gave me a clan name for assisting her people. On Palm Island, which lies 70 kilometres off Townsville, I am affectionately known as Migaloo. To most of the ladies on the island, I am large, and compared to their skin colour, yes, I am white. I was truly honoured as I had been accepted by their community. I have been lucky enough to have travelled to this lovely island for the last 20 years to do their mammograms. So, sorry, there is no smoke and mirrors. Every lady is different. You as a radiographer have to find a connection between your client and yourself. Once a lady has trust and confidence in you and your ability, you as a radiographer will be able to invade her space. But most importantly, she is willing to invade ours. I thank you for your time and look forward to questions. Thank you.
Thank you, Elizabeth, for that very insightful presentation in trying to understand more about the invasion of a lady's space as they come in for a mammogram. And my God, you've got a long way to go when it comes to having to travel for your work. Thank you to all of our speakers for these presentations. May I just ask that Elizabeth, Maria, and Diana, please turn your cameras on. And I have a couple of questions for each of you. Thank you. Hello, everyone, and thank you very much for your presentations. My goodness, I have learned so much in the last 45 minutes about mammography that I never thought I would understand myself.
Okay.
Elizabeth, thank you for yours. It was a very great insight into how it works up in Queensland and how much travel that you actually have to do. I couldn't believe how much you have to do. I have one question though, and that is, what are the differences that you've kind of noticed, I think, between First Nations patients and other patients with respect to making them feel comfortable in the mammography space?
Okay, so our First Nation ladies are a bit more guarded with their emotions, and they do not take an invasion of their privacy very well. So that is why you have to be very considerate and calming, and that's one of the reasons we developed the sister shawls, is because they didn't like undressing, which is, as you know, to have a mammogram, you have to undress from the waist up. So by having the sister shawl, it actually gave them privacy, and it's buttoned at the nape of the neck, so the radiographer can just flip one side off and take the mammogram and then cover her back over and do the other side. So the ladies feel more confident and don't feel like they're being vulnerable.
Yeah, I think that's actually a really good incentive, I think, to have invented that kind of equipment, I think. I also know that certainly in my experiences with First Nations people, and it is actually quite hard to establish that rapport that you would normally be able to establish with a patient, just in a communication aspect. Have you noticed any differences from that perspective?
When we go out to the communities, we make sure as radiographers that we try and integrate into the community. So, like, instead of just sitting on the van having our lunch or dinner, we'll actually make sure we go to the local shop, buy fish and chips, and just talk to the people so that they feel like we are a part of their community rather than just coming to visit. So I think it's very important that you meld into their community and not be a stranger.
Yeah, that very good point, I think. Thank you very much for that. Just moving on to Maria. Maria, that was a great presentation. I think a very big trick is to actually understand the threshold as to when it comes to being able to reject an image or to read, like when you should repeat and when you shouldn't repeat, because obviously there are times where you may need to, but that obviously comes at a cost itself. And we all understand the importance of what a mammogram is, but you mentioned things about with compression pain, that's one of the major reasons why women may not get a mammogram. They might be reluctant to get a mammogram. Mm-hmm. How can we address this? And I know that Diana's obviously talked about tomosynthesis in terms of that reducing that aspect of it, but how else can we address it to ensure that more women will present for a mammogram?
For me? The question is for me?
Yes, yeah.
Yes, I think that it's very important to, it's not so important which mammogram women do, digital mammography or tomosynthesis. We have the advancements, but the more important is to inform the women how important is the mammography. The communication is very, very important for this procedure.
And
so I think,
Sorry, Maria. In areas like Greece, is there a media campaign that happens in terms of trying to inform the public about the importance of getting a mammogram?
There are we work many people to inform the women for this. Yes, the nation must be something. The governments must be something about it, and each other of us who work with women. It's very serious to inform the women how important it is to come again to our department for the mammography. But there are many women who avoid the next screening because they feel pain, because they are afraid. Because of this, I agree with Elizabeth. It's very important to be friendly with the women, to create a very friendly environment, to understand the women that it's very serious to come to our departments for the screening mammography. And I have a comment in Facebook, and I think that it's very nice comment. It's very serious comment from Stephen Samson Boloma, who says that that the cancer, the life without breast cancer is there's no life without breast cancer. Yes, I changed it. I changed a little bit, and I say that without a dangerous cancer. Because of this, we must inform the women that it's very serious to come to us for the mammography to detect the cancer in early stages, where the cancer is very easy to treat it.
Yeah, I agree, and I think that Elizabeth made another interesting point in her presentation, saying that these patients are generally well patients. We're actually asking them to come in for screening. They're not like your regular patients that are coming in because they have a problem already. These are patients that we're just asking them to come in and actually be screened, and that actually changes the dynamic, I think, because you do have to have that kind of that friendly face that comes with it. And that before we move on to Diana, a question has actually come through from Hakon, who is one of the ISRRT vice presidents from Europe. And his question is, are there any male radiographers performing mammography in Australia? I don't believe there are, but Elizabeth, you probably know more than I will.
Up until about 5 years ago, there was one. And as far as I know, he's since retired. So it's a very narrow field, mammography. Yeah. And I don't think many women would like a male radiographer.
No, I very much agree with that. And I'm not even sure how comfortable male radiographers would feel about doing it as well. So
yeah.
Diana, just a question from you. Are there methods that can be done to reduce the motion artifact caused by movement in tomosynthesis? Like how do you cope with patients who find keeping still difficult?
Emotions are very important. They're enemy of our study. We need to breast be hold for all time of tomosynthesis, but we use a little bit easier because we listen our patients. They told us it's the pain they feel is less. They told us when we need to stop, when it's pain, when it's hurt. We speak all the time with her and tell her it's okay. Anytime you feel a pain, it's okay. You told us, and it's individual. We usually use for every patient the different different impressions.
Yeah, that comes back, I think, a lot to patient-centered care and making sure that we're actually understanding a lot about what our patients feel and how our patients feel, to make sure that they are being heard and that we are reacting to what their needs are. So
yes, when they feel our attention, they always can help more. That's important. When we speak with her, she always about weather, about time, about granddaughters, anything. She always can help more. And when she leaves our mammographs, she always says it's okay. They always came with a fear of the pain that's not they can't feel it. But when they leave for the first time, when they finish basic mammograms, they really tell us that it's not so scary. It's okay, and they will come again.
that's really, really good. I think that it brings back, putting in the personal nature of it.
And if we explain to the women why we must make if we explain why we can do the compression, maybe she feels a little bit pain, but it's necessary because of this we will have a very nice, a perfect image. It's necessary because of this. You have a less dose of radiation. If we explain to the women why we must perform compression, or the women is the most of the cases, they is okay to cooperate with us.
Yeah, that's really interesting, I think, because it kind of goes both ways. They need to understand why it's important for us to get what we need to get, but we also need to understand what their needs are as well, and making sure that we're both meeting the same needs and coming up with the same end goal, I think, anyway. Thank you.
I think the main factor in mammography is communication, both from the radiographer's point of view and from the client's point of view.
Yes.
Yeah, I
agree. Yes.
Just one more question before we finish up. This question has come through from Elin Gonzalez, and the question is for Elizabeth. How many screening mammograms does a mammographer perform per day in Australia? And that is both for mobile and for static, on average.
Okay, so I can only speak, and I'm only going to speak on Queensland stats. And for breast screen Townsville, my girls do 26 a day, whether they're on the mobile or in the main unit.
Okay, and just for someone who knows nothing about mammography,
okay,
how long does a mammogram take?
Okay, we have 15-minute bookings, so that allows you time to get the ladies in and out. Yeah. So the girls also have startup times and shutdown time of the equipment, QA time, their lunch breaks, their morning teas. So 26 is a nice number, and we've found that to be the sweet spot, so that we have less workplace injuries, and also it puts a lot less strain on the radiographer's body, because it's a very physical job.
Yeah, that's wonderful. Okay, thank you very much. We are out of time, but I'd like to just give you, the three of you, a huge thanks for taking the time to put your presentations together and deliver those presentations today. I have certainly learned so much about mammography, and it's been a wonderful conversation that we've had since then as well. Thank you also to Angeliki Kalida from Greece, who managed to put this webinar together. And also a huge thanks to Udapon, who is the brains behind actually the workings with putting this onto the Facebook Live site as well. I hope you all enjoy the rest of your Sunday, and thank you very much for attending this webinar. Goodbye for now.
Thank you very much.
Thank you.
Thank you. Thank you. Thank you.